Welcome again. Thank you for taking the time. I know most of you are wrapping up a day of practice, and you must be very tired. I really appreciate you joining the conversation. Um, I can start with a quick intro to those who I have not had the chance to meet. My name is Mahshid Yassaei. I'm the co-founder and CEO of Tali. I'm a computer scientist by training. So I always look at the impact of technology and specifically AI on medicine and medical education with a lot of curiosity. And almost 2.5 years ago, 3 years ago, when we become generally available with our AI scribe, to my naive mindset, I was like, such a great tool, saves time, obviously a future of medicine. We should just drop it into any medical school and leave it at that. And more conversations I had with teaching professors at different medical schools across the country, I learned about so many nuances and considerations that goes into having AI introduced to residents and students and what's needed to thoughtfully do so. And almost 3 years in, I thought it's a good opportunity to have a conversation about this and hopefully break the silos on the learnings that each of us are having separately in different medical institutions. And I'm so incredibly honored to have Dr. Khera, Dr. Varughese, and Dr. Thompson as panelists as part of this conversation. I will do a quick introduction of the panelists and then get into opening with the questions. Just before doing that, each of the panelists are associated with a medical school, a respectable medical school in Canada. Just want to clarify that the conversation and their opinions on this webinar are their own opinions and not the official voice of their institutions. So Dr. Sheny Khera, a practicing family physician and teaching professor at University of Alberta. Dr. Khera has been at the forefront of primary care innovation. I remember that you were one of the first physicians we reached out to for advice back in 2020 when Tali was just an idea. And she is the co-founder of Karma, which is an AI platform transforming senior care. She's also served as president and chair of one of Alberta's largest primary care networks. Dr. Thompson, a practicing family physician as well, and adjunct professor at Western University. Also, one of the early visionaries behind the adoption of AI scribes in Canada, beginning in 2023. He has continued to lead in this space as a peer leader with Ontario MD and an executive member of OMA's Digital Health Working Group, Section for General and Family Practice. Dr. Thompson is also a respectable voice on compassionate care and the role of AI in improving patient outcome. Dr. Varughese, a family physician and a medical educator. He serves as the president of the Ontario College of Family Physicians and is serving as an interim assistant dean of primary care education for the School of Medicine at Toronto Metropolitan University. He also serves as the physician lead for the TMU Integrated Health Clinic, which opens its door in January 2026. Congrats. Amazing. Thank you so much for joining again. Just a reminder to all the attendees that you can join the conversation by dropping your question in the Q&A box. And you can also upvote other people's questions and we'll try to get to them toward the end of the webinar. Maybe we can start with the first question just as a starter for the conversation on share your opinion on what you are observing your institution's reaction to AI scribes. I see different institutions are being either piloting or just observing the space or being looking into policy and the regulation side of it. Where you're seeing your organization be and what has been the primary factors into being at this stage as you are. And maybe we can start with you, Dr. Varughese, because you're having this opportunity to build a medical school fresh. So we'd love to hear your thoughts on that.
Yeah, absolutely. Thanks so much. And thanks so much for having us. I think honestly the biggest thing is that there is the ability to implement every single new technology that comes in through the door because it would just make life easier. But doing so in a bit of a strategic way and a way that allows you to make sure that what you're going to be implementing isn't going to be a new thing that gets in your way, but actively helps you. And so when I think about AI scribes, we've seen already in the data, there's been 3 to 4 hours per week saved. And the ones who don't have time saved just feel better because they go home with less cognitive load. So I think from what I would say with this is that in a day-to-day activity, it definitely helps people who have created frameworks and ways to discuss with patients on what they want to do. Where I think we will need to be cautious and where we'll continue to need to build some research base would be how we include that within medical education, especially early on when many of our learners are building their own framework and understanding how to have those conversations with patients. The more that we offload it, the more likely that people will get over rely on it. And the example I always use is the rear view camera. If you over rely on a rear view camera, you could definitely have blind spots and get in an accident. Versus if you're using that tool and checking your blind spots and looking behind you, you're more likely actually going to get more benefit out of it. Thanks.
Amazing. Dr. Thompson, maybe you can share with us where is your institution and what are the considerations on integrating AI into
Yeah,
the.
excellent question. And I sent out a panicked email to my colleagues because I'm adjunct faculty. I say I'm a pseudo prof. I'm not a real prof. I say, hey guys, what's happening in our realm? So a couple of things. We have began a process of setting up an AI meaningful solutions in primary care. And one of the tools we're going to start with is AI Scribe, looking at how that impacts patient-centered care. And we know it saves time. It's that currency of time. But here at Western, we're most interested in that compassionate, longitudinal, comprehensive care, all those principles spoken of by Dr. Ian McWhinney, why patients come to see us, but putting their illness in the context of their lives. That takes currency of time. So it's an incredibly valuable tool. And I think our academics now are starting to realize that. I heard literally just today that one of our teaching centers, they're on TELUS, and they are, yes, going to proceed with integration of one of the AI scribes and start using it for year two residents only. We have felt that, we have to teach them the analog methodology, right? You got to learn with the stethoscope and listen with your ear before you move to the more advanced tools. And so I think that's the approach we're taking with the AI scribe. But truthfully, a lot of unknowns, like the questions and discussions we may have around those outputs and looking at that note once it forms out, there's going to be some fascinating research opportunities. That's what's gotten us excited, right? And at the end of the day, does that note represent the true flavor and context of the interaction with the patient? And think of it this way. If I ended up in court, civil litigation, pertinent negatives, pertinent positives, I look at that and know, is it going to protect me or is it going to help me defend in my thought process? And if it's doing a good job at that, I don't think it matters which tool you're using, but are you satisfied to understand that output? And then lastly, we've moved beyond just the context of the clinical note. We're seeing the AI scribes move into the ability to do forms, right? To do patient summary, to even do some clinical decision support, which maybe we'll get into a little bit later. I have my own thoughts on that, but really it's going beyond just the scribe itself. And so again, another area for us to study and how that's going to impact our learners and their comfort with these tools.
Amazing. Thank you so much. Dr. Khera, where's University of Alberta? What are you seeing contributing to the process?
Yeah, for sure. I just wanted to also echo what my colleagues have said here too. I think all those points are very valid and important to consider. I just wanted to share even just myself as a member of the Department of Family Medicine, where we're involved with the residency program. I think what we're seeing at our institution is a bit of a staged competency-based approach. So residents at this point can use AI scribes, but that's when the site has approved policies or preceptors are supervising them, and the or resident has already demonstrated that competency and that strong clinical reasoning and documentation skills. So now it really is an asset to them and not taking away from their learning opportunities. Right now, we've sort of shaped it up as an interim policy. Our school right now is going through accreditation. So again, we think manpower, that's our focus right now. But even with this interim policy, I think the value actually isn't really the policy per se, but the active discussion and looking now at the real world application and the discoveries that will come out of this. So I think we've really done a good job of that. And also the introduction of some curriculum to sort of build that faculty and resident AI literacy. Because I think these are those foundational pieces that we need to have in place. When I think of my role in the undergrad education space, so that's with medical students, I'd say maybe there we're even a bit more deliberate. As my colleagues have mentioned, we sort of know from medical education literature that there's a lot of cognitive learning and reasoning that happens when you see a patient and you create your own note before the AI kind of does it for you, right? There's a lot of active thinking, review, developing differentials, and all those pieces that you don't want to take away. And I think the concern is if we introduce the AI too early, are we now going to be risking de-skilling? But learners so early, maybe we're actually never going to be skilling them, right? And so I think it's really important to ensure that we're doing that in um, a sequenced manner. And I think that's sort of what the MD program is doing, is sequencing that AI quite wisely. So exploring those early low risk exposures so that they're prepared for the AI enabled workplace that they're going to go and end up working in. The last little piece I wanted to just share, because I do wear that sort of co-founder digital health tech and research hat, is I would say that the U of A research ecosystem is quite engaged in AI innovation. And here I would say we're sort of more on the evaluation side. So we do have a major provincial project that's underway here that's been part of the co-design, implementation, and evaluation of AI scribes in Alberta's emergency departments. So again, sort of on that cutting edge of things. And I've been noticing here too, a lot more intersection between the computer science experts like yourself, Mahshid, and healthcare. And I think that's really building opportunities to really do some great cross-pollination, understand each other's languages, and really start building that framework of the evaluation of these AI tools in active clinical practice.
That's amazing. I'm just curious in the sequence that you mentioned on the step-by-step introducing AI scribes or AI in general to both undergrad and residency programs. Um, where do you start designing, or do you start designing a policy or a framework around shaping that opinion around how residents are going to be trained on AI? At what stage does that, or have you started designing that framework or guiding policies?
I think we've started some of the preliminary work, but this is where, again, I feel so lucky to be sitting on this panel with other people across the country, right? Because I think we're all kind of at different stages of this development. And I really think we need to sort of get those leaders to start talking to each other, right? Because how do we map that out, right? What's the ontologic map of when that trainee has achieved that level of competence that now you can say, let's just level it up and add AI in there as well. So I think having conversations across the nation and having, the key leads and residency programs to start having that discussion. When it comes to competencies itself, I would say it really is no different than the competencies we're already instilling in our learners, right? We want them to be able to have great communication skills, talk to patients, be able to create that summary, do that critical thinking, analyzing the evidence, and all those components. And then now you would just sort of layer that up with AI there as well to sort of again critically evaluate the outputs that are coming from the scribe, and being able to assess and at the end of the day taking the responsibility that you own that note as well.
I would add into the Sheny as well. I think the CCFP and had started this process, and there was a committee that got together. What's the review of the curriculum? And one of the things mentioned was, could we have sort of the equivalent of a Google Share document that we're all putting into, right? And I'm not sure where that is, to be honest. I'm a bit naive. I participated in that working group, but it seems like things went sort of dim. But I think this is an excellent opportunity to re-spark that interest and maybe get some further collaboration. Exactly as you're saying, we're all at different stages. What's worked for you and your institution, and we learn from each other, right? And maybe get a final product or final iteration that we're on similar pages. So yeah.
I would
Mhm.
agree. And I think one of the ways that this comes up is we have to sort of do a twofer because we have to obviously improve our ability to have the policies and the necessary conversations with regards to medical education of learners. We kind of have to do the faculty development of our preceptors just as much. Our clinical teachers are sometimes walking into this being expected to know even some of the basics or what the widespread of AI means. There's many people that won't understand some of the different conversations, some of the ecological impacts of new novel questions being put out to AI. We had a conversation about this yesterday with some of the students that one of the biggest things that people are talking about is they want to create a bedtime story for their kids. So they ask ChatGPT, and that actually has some pretty significant impact. And so thinking through what all of these mean and how best can we do things in a way that allows us to create a product, if you will, or a way to be able to do this that is standalone, that allows us to actively work together. But from a policy standpoint, I absolutely agree that I think there is too many people having to recreate the wheel. Having a universal language, universal kind of starting point will allow us all to be able to start from a place that we can say, we all know where we want to go. We know what our individual needs are from competency-based medical education. And now it's a matter of tailoring it to a much more nuanced conversation as opposed to having to restart everything from scratch.
I wouldn't have
That
been able to tell you what machine learning was or convoluted neural networks was 2 or 3 years ago, and I'm learning awfully fast, right? Or what's a large language model? Just learning the lexicon and the way that the scribe works and interprets, and the conceptual, right, and behind and how it goes, and honestly, transparency of vendor. I've shout out to the vendors on the vendor of record, right? Because that really helps. But when you ask a vendor, tell me, how did you eliminate hallucinations? That's proprietary. Can't tell you that, right? So we have maybe a conversation later about the regulatory side of where things may need to go. But I think that's going to determine, quite honestly, which tools get adopted into the curriculum, because we're going to need that trust. And part of that trust is based on I need to understand how it works, how it may make mistakes, and what could go wrong. And that's going to be really, really interesting, especially as I said, as it's a creepy crawly going through the EMR and starting to offer differentials. It can listen to the conversation and say, Webb, here's a list of possibilities. Now we're into a whole other territory, right? With these scribes, and what's that going to look like in a curriculum where we're trying to teach the basics of the medical skills, proper history, physical exam, and move right to the final conclusions. Fascinating, honestly, but they're really challenging.
very interesting. And I just there is a comment or question in the chat by Dr. Anderson that's saying that remind me, it's not, maybe it's not the exact question. I'll ask that question and we'll get to this comment. Is that it's a kind of a both way learning between AI and clinicians. Obviously, we're early days of this wave of technology, but there are cases like if we know AI, let's say AI scribes as one of the hopefully low risk uses of AI compared to like clinical decision support and those other use cases, that the clinician, for example, needs to change some things about how they practice. An example is like I remember early days we were telling clinicians like if you take the blood pressure, just say the blood pressure to the patient, say it's 120 or 80, something that they would never do. Or when you're doing physical examination, I saw that there is a little bit of a solo here. So this is like if this is going to be part of the future of medicine, then there needs to be those changes that are communicated as well. Is this happening, or what are you seeing on that front?
I think one of the best things about that is it becomes a great teaching tool, right? There's many times that I'll have a learner with me and I'll be talking to the patient and the scribe exists and it's taking in things. And because I'm talking things out, I'm able to teach to the person standing to my left. I'm able to give the information to the scribe, and the patient benefits as well. So I actually think there's a lot of benefit from it. And it's actually good for when we're doing things with the learners too, because we tell the learners that too. We tell them you should talk out what you're thinking and how you're thinking about it. And it goes to even the comment that was there in the chat about this idea that there is some benefit in talking through your differential and working it out, and then reviewing your scribe or your information. I think the interesting kind of connection point there will always come down to, will you review that information, or at one point will you get so reliant on it that you're like, it's so good, I never have problems with it, I'm not going to review it. That is something we have to be very careful about. And I think we absolutely need to consistently look back, even if we feel like 99% of the time it's fine. That 1% of the time is going to get you.
Yeah, I totally agree with you. I was gonna say the same thing. Like we've been a teaching center. I practiced in a teaching center all my life. I actually trained at the site that I'm still at,
Ah.
the site director of. And so when learners come through and they're practicing for their OSCE exams, very intentionally we tell them you have to say it out loud because the examiner in the corner has no idea what you're
Mm.
doing otherwise. Then we get into clinical practice and we become like mute. We stop talking. We just
Mm.
go off and do our own thing and come back. And so I'm actually, again, I like this revival of saying things out loud. And within our practice, we've always done it that way. And our patients are so appreciative because now they actually, their level of engagement with in the encounter has just gone high, right? Because now they also are understanding and listening and doing all the rest of it. So I know you probably did have to train people when they were getting onto the scribe to start doing that again. But I think, as Jobin said, there's a lot of value add to that. And now the critical reviewing is to watch that we don't just assume that it captured it right every single time, right? At the end of the day, even when I have a resident who's not using the scribe, for example, has done a clinical note, I still go and review it until I feel that they are now at the level of competency that I hand it over to them to then sign off on that note. I still, take a quick look, but I've given it to them. And I don't know, are we going to get to that level with AI tools that our level of trust with them is that same that I've just built with my resident that I handed it over? I don't know. I think that's still kind of things that we'll have to wait and see.
Yeah, and I love that scenario, Jobin, that you played out with the AI scribe simply in the ambient mode and some of the interactions that you have with patients. It becomes more open conversational. I'm speaking my thought processes, but it really does change, right? That patient-centered care approach, that shared decision making. And I find myself getting into greater depth in some health literacy discussions because I have that currency of time to do it. I didn't have that, right? It was kind of a rush to get through, efficiency over efficacy, and I really value that time. And I think that's a wonderful use case that you described.
Amazing. Want to maybe connect the next question to a question from one of the participants or attendees, Dr. Gardizi, on the security and safety of AI scribes. I know in some jurisdictions there are leadership from, for example, in Ontario, from Supply Ontario or Ontario MD on trying to design and define like, well, we looked at this AI scribes. This is a list of AI scribes that are safe to be used. Some other provinces have done the same. Do you think in a medical school there needs to be higher standards, independent review of security, privacy, and how would you pass this responsibility if it needs to be done to your residents and students, that they would have to be part of that security and privacy conversation probably forever.
I'll jump in there. I mean, for us, our university it makes us do a privacy and security screen. So regardless of whatever, like Ontario MD doing it or not, we still had to go through a privacy and security assessment. And I think when you start getting into institutions, that's already going to be built into the way that things are going to be implemented. Um, I think the bigger question would be a clinic that isn't associated with an institution, that isn't associated with a university, or maybe is a community clinic that does distributed medical education. So that actually learners come to you, but maybe you're not actually underneath the university's network. You have your own network. I could see this coming up very, very often. I think that having any sort of validating body, somebody else to do that work, does make it easier. I think the delegation or the conversation is, do you trust it, and how well validated it is that there is a need for the scribe AI companies to actually do their due diligence. I think it's a lot of work to try and ask each person to do all the due diligence necessary. So one of the things that could be considered is go through the places that have, like Ontario MD or elsewhere in other provinces, that have done that work, and then see, what else would you need in your own clinic, so that you're not having to reinvent the wheel. Just going back to what we were talking about earlier.
Yeah, we're fortunate in Ontario to have that vendor of record process because that really does ease our uh, looking for trust, right? It simplifies that process. And one of the challenges I've noticed, like I'm community based, so you're absolutely right, Jobin. I have students that come in and host and observe. I've got my tech person, and I trust that he's gone through everything. We don't all have expertise at our fingertips. The one of the barriers I understand to the education of it and using AI tools within the hospital has been that governance, privacy, and security very strict. And this will be interesting also with our OHTs, some of those being hospital centric, and ultimately the tools that we're using in the community and what's going to become part of, is Cerner and Epic going to become the next Microsoft and the AI tools that they adopt into their system, and then we try and farm that out into the community? Are we going to have to give up our current EMRs? Is everything going to move to the cloud and then it'll become irrelevant what EMR or other tool we use? I don't know where that's going to go. But right now, there's definitely a disparity between community-based and the tools that we're quick to adopt or whatever. It's a lot slower, certainly within the hospital because of those governance and privacy restrictions.
And I would actually say that there's a lot of benefit. Sorry, Sheny. But I would say there's a lot of benefit in that simple act of having everyone on one system that talks to each other, because interoperability is so critical. One of the biggest things that we all recognize is we don't get the information we need. We get information dumped at us. And instead of being able to know what's happening in a transition from our patients going to the ER or within a hospital stay or to long-term care and then coming back to us, we'll get things PDF to us. We'll get it in text. Sometimes a dot matrix printer will give me a printout of it. The fact is that we need that interoperability, so it's not a situation where you're constantly having to chase data. I think this is a big thing that we'll have to do. Sorry, to jump the line. Go ahead, Jenny.
Okay, no, I thought Keith had his hand up, so I was gonna. He's just pressing buttons.
Accident. I was looking for the smile emoji, but couldn't find it.
Yeah, I was just going to say, so again, I am fortunate because I am at a academic teaching site, which means I get R1 and R2 residents and medical students. I then am really, really well supported. So when it comes to, as you guys were mentioning, how do I know that the tool I'm using is passing all of the regulatory requirements and institutional requirements? Well, that's all done for me, right? But I still think, though, it's important for us to also have that a level of awareness because I have some community colleagues who are so well versed, right? It is a lot of effort and time, but because they have had to do it on their own, man, they know the ins and outs of terms of use, privacy policies, where the data is stored, where that cloud is. They know all of those pieces. So I think at the end of the day, we all need to have a level of awareness of those components because I think it is critical when you're using any type of tool of any kind. But on top of it, though, I think that we do need to make sure that we support the community physicians to make it a bit easier for them as well. So if that's linking them back to, the departments of family medicine, where they're already, affiliated as clinical academic colleagues or clinical faculty, or even is this one level higher? Like here in Alberta, we went and we're going through a very large system change. We now have a Primary Care Alberta pillar basically for the health system. And is there a role for Primary Care Alberta to better support community practices so that we can be maybe somewhat at level ground with the acute care settings, where when you walk into the hospital, all of those things are done for you already. The team already exists, the checks and balances for regulatory requirements on all digital tools are all done for you. We don't really have that same setup in the community, but could maybe Primary Care Alberta should take on that role as well? And not necessarily just them, but wherever we are in our different provinces.
Just wanted to verbally say what I wrote in the chat just because you're recording, and because I think it's important. There was a comment about this idea that it would have been so much better if we had like a single standard or one solution that could have handled the interoperability and all that. And I think the fact is all of these different solutions started getting developed around the same time. In 2020, the little bug that kind of went around and destroyed the world, this kind of meant we needed to have something different. And so I think that part of it then meant that now we have a bunch of different options. And if you ask a whole bunch of different people what they think is best, they'll each have a different experience and therefore they'll each say what's there. So I think there's that part of it. There's also the fact that if we end up having just a couple of people in the system that own kind of everything, we'll kind of get a situation where there's no real reason to innovate. And then you'll get a situation where we get this really bad product that exists that everybody uses, and there's never really an interest to make it any better until we get some competition. So I would argue that having a whole bunch of different services that meet one issue, now they're having to each beat each other. And this means that they're actively going to get better and force each other to innovate. I think the biggest thing is making sure that there's a standard and a set way that people can jump into the system, hopefully at a point where the government recognizes that having it paid for actually helps patients, helps the wellness of physicians, and it helps us communicate better, and also decreases a lot of the issues with regards to some of the administrative burden that exists within physicians with regards to AIs improving forms within the ability to help with that.
It's going to be interesting to see how quickly these tools evolve. And I think that's the other thing I'm fascinated by. Literally, we first talk we did on AI Scribe, and we mentioned a few of the tools that were out there. And within 2 months, by the time the slide deck was ready, there was already 3 or 4 more. And the same with other AI solutions, right? It's sort of they're just popping up like mushrooms. And also that issue of vendor lock. The tools that I choose, I'm married to my particular EMR. And so that may limit what I can use in terms of the various AI scribes and the different integrations. And how is that going to look as well, right? Like not only from a costing standpoint, everything I add, well, I really want AI scribe. Well, I really want patient booking. Well, I kind of want a clinical decision support tool. Ka-ching, ka-ching, ka-ching. I don't think that's sustainable over the long term. And what is this going to look like on a teaching perspective? And we just prepare them, and by the time they finish, 2, 3 years down the road, well, guess what? There's another version here that's better, or we've changed to some other new platform or solution. So that's going to be interesting.
I can confirm that competition is keeping us at the tip of our toes for sure. So it is working. If it's by design, it is working. So I want to get to the next question, linked to a comment in the chat. Just a story, almost now 3 years ago, when the first version of Tali went out, it would just listen to the conversation and spit out the most simple soap note you could imagine. And that was what was out, and even that, like with the first few visionary physicians, they were excited, they liked it, and then as more physicians get started with AI scribe, learn, oh, I actually need my subjective part to be more detailed, but the objective to be a little more in a bullet format, and I want this part to be in third person, but that part to it, and then And it was like a never-ending set of requirements on every physician, every clinician wanted their note to be written in a specific ways to obviously to the comment that's in the chat, because this is how the real-time save comes in. When you go back to look at that note, um, it would be easy to understand. I get that, but it turned into such a complicated technical problem to solve that at some point we had to give the tool to physicians to just give us your instructions in natural language and we'll get it and try to fix it on the back end. And still to this point, I think getting it exactly right is a challenge. I want to get your opinion on when you are putting a product that is so personalizable and customizable in front of residents, are you envisioning that the program will actually give the instructions and personalize for residents when they're ready to use it? Or would you give that flexibility to residents, whether they're second year or whenever they're ready, to actually own their notes when they're ready to own their notes and customize them the way it works for them?
I think the current generation of learners we have right now are digitally native. They're jumping in. They're already using some version of AI in the way that they do things. So I think that there will be some amount of individualization, things like that. I would challenge that it's the opposite we need. We need standardization so that they can figure out the individualization when they get out into practice. Because the practice they have within their training is actually quite artificial, right? It's they have access to teams, they have access to resources. Oh yeah, I need a social worker right there. I got one right around the corner. That doesn't exist everywhere. So I would actually say that standardization allows them to have a little bit more of an ability of what things do I need to ask? How do I ensure that I have the largest scale of things in front of me? So then when I get into my practice, I can individualize it based on what resources I have around me. So I would actually say that when it comes to like standardizing or sorry, individualizing AI scribe, for example, if we make it overly sort of individualized within the format that they're learning in, and then they get into a practice where, maybe they don't have access to a lot of different flow charts and things like that in their new EMR that they had to move to. They have to retrain that. They start from scratch. But if we give them the out of the box, this is a standard and this is what's going to give you the biggest bang for the buck, we can drop them out of a helicopter with their parachute, land anywhere, and they'll be able to practice. And they won't have to reinvent everything and learn their new community, learn their new surroundings all over again.
Any comments from you, Sheny or Keith?
I'm the least qualified to answer that question. My experience in the community, I host students have been focused mostly on research, to be honest, and looking at that realm. So I'm re-experiencing bringing learners and observing in the office. And so I'm probably biased just by my experience within the litigation side, right? And looking at notes and defending situation where there's been a complaint or there's asked for a review. And as I hinted at earlier, my approach has always been simply the structure you want. You can personalize that, but at the end of the day, right, have you carefully captured your thought process, your reasoning, your intuition behind what you did? And has it got those pertinent negatives and positives? Yeah, there was, it wasn't an explosive sudden onset of headache suggesting a subarachnoid. You were thinking that and your note describes that. And if the AI can capture that, whether it's bullet point or whether it's, more paragraphic and flow is different, that doesn't matter as much to me, but I know what Jobin is saying, extremely important. And my last comment is just not to terrify people, but there is yet to be a civil litigation where we've compared, right? Patient said, doctor said that involves the use of an AI scribe. I haven't seen that directly yet. And I think that may determine standard of care. And on that last note, just be aware that patients now have access to their own AI scribe. These tools are coming out where they can come in and record the interaction with the clinician. And then the purpose of that is to summarize which AI scribe, right? So your platform can make a patient summary, but patients have their own tools now for doing that. And so what might happen in a civil litigation where the two notes differ, right? What happens in the hallucination in one solution that the patient has versus what the doctor has? And yeah, standard of care, I think, is still, we know what it should be, but how that's actually going to play out will be interesting. And not, listen, that shouldn't stop us from adopting these tools. Don't get me wrong. I think in my experience, this has improved the quality of the note in so many ways for myself. It's made me a better clinician in terms of what I'm able to notate. But it's going to be really, really interesting, right, to see how the use of these tools might play out in a court of law if there's a question about what's in the chart.
Yeah, it's interesting. Like a few months ago, a physician has reached out to the company's contact us form with urgent, I need to talk to the leadership. And so I took the call myself and I was like, what's going on? And apparently there was a case and the patient and the doctor didn't agree on some stuff and the patient got angry. And he actually wanted the recording of the conversation because he was saying, I want to prove, I want to show in the court that I actually was behaving the right or doing the right thing. And I was like, I'm not lying. We don't have the audio file. So it's kind of a double-edged sword sometimes, and you don't know which one is it going to be helpful to you or not. I think you're right. If the patient has their own tools now and the physician has their own tools, it's only the audio file that maybe could solve the problem, but I don't think any of the vendors are keeping the audio files as of now.
And I mean, those tools are really just summarizing, actionables for the patient. And it helps with their health literacy. The one I've tried, I honestly, I love it. I said to my, go ahead, use it, not a problem. Now, maybe I'm shooting myself in the foot when something comes up later. That's an interesting case that you describe, right? They want the metadata. I said this. I did not say that, right? Wow. Interesting. So I'm glad to hear that those recordings don't exist.
Yeah. And I do think that there's a lot of, like, depending on how your relationship is with your patients, there's a lot of things that can just sometimes be said that's not the what you mean, but it's what you say. There's a lot of these kind of things, and I do think that there's, if we're thinking about the medical education side, there is that risk that people are not going to gain that ability to have that communication in a way that feels organic. It's much more, I need to train this AI to pick up what I want to say, and if I say anything outside of that, maybe it's not picked up at all. It's considered extraneous. But maybe it was that I asked the family history and it turned out that person died really recently and I gave, supportive counseling about it. Didn't catch it in the note. Maybe there's some areas there. There was a comment in the chat about the actual documentation skills when part of the note is generated or shaped by AI. I think this is a very real conversation that we have to have, which is, at what point is it appropriate for learners to be using AI Scribe specifically for that reason? Or is there two notes and that you kind of say, like, this is my kind of scratch notes and I'm going to keep it, and maybe it's in a separate area, and then these are my actual, like, notes. But I think of this very similarly to the way that we dealt with templates. There's a lot of people that use templates, and there's a lot of people that overuse templates, and templates lose a lot of the nuance. Very similarly, over verbose AI scribes can lose some of the nuance of what's being said and how it is, and sometimes add in some pertinent negatives that probably should have been asked, but maybe wasn't asked. And so I think part of this needs to be understood about, you're going to be held to what's written, and very similar that definitely what is recorded. But
Any comments from you, Dr. Khera or Dr. Thompson, on this?
Yeah, no, I was just gonna comment a bit earlier on, just when you talked about the degree of customization. So again, just sort of with my own health technology, where it's an assessment builder, and we're doing geriatric care, again, it's that push and pull that standardization is actually essential, right? We need to make sure that the people who are doing these assessments understand the components of the questions that you're asking, the rationale behind why you're asking them before you get too detailed into like the format or the design or like how you prompt it to look, right? So I think that that's really essential. And I feel the same pains when you go talking to users and they're like, well, I really want it to be exactly like this. And you have to stop and be like, well, do you understand the logic behind that or the workflow that goes into that? Or why these questions are being asked the way that they are, because you do need that standardization for sure. The other piece I was just going to say, I guess, is just a little bit about, people when we use the AI scribe, I have to inform my patient that I'm using the AI scribe and I describe it, right? That this is a tool to help me with my efficiency and making sure we capture everything. But then you can imagine this hasn't happened to me yet, but I think in the chat a few people were saying, what if the patient comes and says, oh, Dr. Khera, I have my scribe that I want to, use and sort of capture everything that we're chatting about. So I don't know if people have encountered that or how you handle that. So I just thought that was a sort of another sort of flip of like when now the patients are coming equipped with their tools.
Yeah, it's an interesting realm, right? Because we cannot legally refuse to allow them to record, as I understand the health law currently. Hopefully they ask and ask our permission, but we ultimately can't refuse. But doesn't go the other way. As clinicians, we, as the health information custodians, we have to ask their permission to record, and they have the right to decline. I've only had one patient decline who wasn't mine, and he was a retired RCMP officer. And interesting, this discussion about health privacy. He says, Doc, he goes, there's no such thing as erase recordings. If we want it, we'll get it. I don't really want my information recorded. Thank you very much. I found that fascinating, right? So yeah, don't know what CSIS is able to pull out of the metadata there, but apparently it exists somewhere. We think it's erased, but maybe not. Mahshid, we have to look into that.
I just wanted to, Mahshid, just add one more sort of pragmatic way of using the AI scribes when you are in a teaching clinic or you have a learner. So I can use the scribe, and I'm using the scribe. And I have a medical student who is not at the level to be using the scribe. So the medical student still going in, talking to the patient, coming out, we have a discussion, and then we go back in. But I've probably already seen another patient or two in the interim. And so now I can use my transcript from the AI, the dictated note that came out, to sort of sit with the student and say, hey, I'm going to just review this note with you, and now you can use that as an educational tool. The other way that I'm using it is with my resident learners is we do direct observation. And there's barriers sometimes to do direct observation. If I'm in the room with them, observing their encounter, I'm a total distraction. The patient's attention is totally focused on me, and it's not even a good capture of that resident's capabilities. Now we have cameras that don't that just sort of capture the conversation side of things, but that too is a bit awkward, right? Because now the resident knows that they're being watched, and now I think stylistically they're also a little bit, not their normal selves. But the AI scribe, if I could get the raw transcript, so if everything that I kind of encountered there, then I can review it with the learner. I could look through that and say, oh, here's where the conversation sort of went off in here, but that could have been an opportunity to interject and maybe talk about this. Or I noticed that the whole conversation was directed by the patient's agenda. Were you able to sort of fit in your questions and things like that? So I think that there are different ways that we can work with vendors as well, to look at things, not to keep it forever, because I know you don't keep the raw transcripts, but in a way, even just as we're kind of mapping out our collaboration, right? As educators with vendors, and learners, how can we sort of elevate that, and maybe even use the tool in very different ways?
Yeah, that's a great point. I think part of this conversation for myself was, and I know for all the other vendors, is we want to make this like kind of a two-way conversation of, well, if you give me this thing and that thing for a resident, because I think, well, most vendors are the same, but Tali is free for residents and students. So we want to drop that barrier, but we know there needs to be some more support in the tool itself as well to match the workflows of teaching clinics. So suggestions are like that are really, really helpful. Dr. Varughese and Dr. Thompson, do you have any ideas on collaboration between vendors and medical schools that you want to add?
Well, that's really what we're going to look at within the AIMS PC, we're calling it, Artificial Intelligent Meaningful Solutions in Primary Care. And this is one of the things that we want to study. And we're going to push the envelope a little bit, we hope to, because we have a catalog of expert patients, but we want to look at the use of these types of tools when there are challenges, right? Be it hearing impairment or English second language, or elderly and difficulty in giving a history, or maybe speech impairments, etc. The use of these tools in that domain also will be important, and what changes will be made during that interview or encounter to capture. Maybe it'll fall back into more of dictation mode as opposed to ambient. It might be more appropriate. And these are the things we want to learn, and just how the patient feels, right? How's the patient feel about me commenting, oh, I'm feeling a mass here in the right side, right upper quadrant, tenderness rebound might sound innocent. Maybe some patients are going to be terrified by that. We might not normally. So the ability to write it in a little template in the side and make our comments and bring it in without necessarily speaking it loud to the patient would be another way to use these tools, right? That might significantly impact that patient-centered care approach.
I think with all things, it comes down to, can this be done in a way that allows us to work as freely and as cleanly and as efficiently as possible? And the more that we're kind of talking it out, we've already talked a little bit about this, but the more that we're talking out, the easier it'll be for things to go. But there was a comment in the chat about the idea of some of the masks and some of the accents and some of the different errors that can come up when there's things that aren't perfect. And I love the idea of the translational, like, I'm not gonna, it's going to be much harder for me to translate out something, hope it works out well, and send it as a patient handout, versus knowing that can get done would save me immense amount of time, might save me some back and forth with family members who maybe I need to communicate to be able to share that information that we had in the room. And so there is some kind of areas there, and especially within sort of our clinic, given that we're starting up, there's going to be a lot of work within the equity, diversity, inclusion, accessibility realm, where a lot, because Brampton is so multicultural, doesn't matter how many staff we have, we're never going to have the right translational services. And so having this ability to be able to do it in a meaningful way that patients can be like, oh yeah, that's exactly what I was looking for. That's wonderful. And out the door they go, is going to be a huge saving of time, but also is going to have immediate patient benefit.
Mhm. It's interesting. I just remembered that in one of I think it was actually at Western. I was on a panel and I was just bragging that like initially we were worried that patients would not give their consent, but 99.9% of patients are actually okay with AI scribes. And right away somebody raised their hand in the audience and said, "This morning I went to see my doctor. They asked for my consent and I did not give my consent." I was like, okay, thank you. Why did you not give your consent? And that's exactly what she said. She said, I have an accent and I had my parents with me who don't speak great English. And I was worried that AI might not be able to capture the nuances of the accent and the conversation properly. And the doctor would not have time to review properly before putting it in our chart, which was an interesting, eye-opening comment for me as well. There is on that front, on the translation side, and I know there was a question about this in the comment as well. So there is a part where, like, I don't speak English with my own family doctor, as you can say see from my accent. But Tali is trained, or most AI scribes are trained to listen to a conversation done in another language and document. The challenge comes when the patient is speaking a different language than the clinician. And the technology is there. I think we can do it with a reasonable accuracy to do the live translation, as you've seen it in other, as the comment says in Google Translate. The challenge we could not overcome is the liability, because there's nobody there to confirm that the translation was done right. And if there is like even 5% chances that the conversation was not captured, who is liable here and who is responsible? I know there are some movements in this space. Some technology companies are going there. The part that we're trying to yeah, the accuracy is going to be a challenge, but it's getting there. I think it's becoming as accurate as maybe human translator. It's just the matter of the legal part that's hard to navigate. Thank you so much. It's been a great conversation. Maybe some closing remarks if you have anything you want to leave the audience with in terms of any tactical takeaways you want them to have from this conversation. We can go around and then close the conversation. Maybe we can start from you, Dr. Thompson.
Yeah, just patient-centered care, efficacy versus efficiency. I know the public need is to increase our time and capacity and attach everyone to primary care. And certainly these tools give us time to do that. But hopefully we don't lose sight of what really it is to connect with our patients in a relational aspect, longitudinal, comprehensive, right? Understanding their condition in the context of their lives. And even just this conversation around the translation of their native language, right? As ESL. I mean, that's incredibly important towards building trust within that clinical relationship. So I think these are really powerful tools to help that.
I think the biggest thing with all of these comes down to when we are talking about bringing in tools that are going to help us with patient care, we're going to be much more inclined to just jump on whatever we can do to make ourselves more efficient. When we start bringing on learners on top of that, brings on another level of, making sure that we're getting our ducks in a row. So I would really kind of encourage us to, as we've already seen in the chat, try and get to the point where we can start pulling in some data, get some ability to have some universality in how we're going to start from, and then allow us each to be able to nuance it for our individual areas. I think that one of the biggest things that we're going to benefit from is getting to the point where everybody here, every family physician, every specialist gets the ability to have the digital tools work for them instead of getting in the way and being the thing that they have to kind of train or get to the point where it's really being a burden and a new burden. And so that's what I really want to see, and I think that really comes on it in a strong way. Thank you.
Just wanted to add two things. One is I remember going from the paper world to the electronic medical record and the promises that were made about how it was going to help my life. And instead, it just became so intrusive. It's everywhere. Even after this, I'm going to do some chart notes. I'm going to look over some tasks. Do you know what I mean? And I finally feel that now with tools like AI Scribe and where it's going, the trajectory of where technology is going, I think we're going to get there if we're not already right at the cusp of that, where it really will be my assistant, right? So that I don't have to keep walking in and out of the patient room to look for things. I don't have to disrupt my conversation to go to my computer to find stuff. It's just such this dynamic flow and it's just working so beautifully, right? And that to me is just would be so amazing. My second comment is exactly what Jobin said. If it has to do with me and I'm already a competent physician, I've been in practice for 20 plus years, I will jump right on it. But now throw some medical students at varying levels of abilities, throw some residents who also want their autonomy, but I want to make sure that you got it right and you know what you're doing. It just adds a whole other level there. And I think in that respect, I think what we really need to do is, again, recognize that AI tools are here. They are transforming practices, but their success or their impact will depend on the preparation of us as healthcare providers. That's from learners to, experts or whatever, the governing responsibilities and the partnering and partnering wisely. Because done right, it's going to be just amazing the things that we can get going. And I think we just need to be very deliberate and grounded when it comes to the medical education side in those principles that we already value in the science of learning, in medical education and clinical practice.
Amazing. I think those were perfect notes to to wrap the webinar with. Thank you so much. By the time I know physicians are busy, by the time it took us to schedule this webinar around your schedule, I know you are all very busy. I really appreciate your time. I appreciate every attendee that took the time to stay with us and engage with the conversation. You'll all receive the recording of the session, and you can find it on our YouTube channel as well. Thank you so much. Have a great evening.
Thanks, everyone. Good night.